Welcome to the Radong Smart Review Head and Neck Cancer Series.
This is a comprehensive tutoring session designed for residents at all levels, focusing on the definitive chemoradiation strategies for locally advanced head and neck cancer.
Our mission today is to give you a bulletproof understanding of the clinical evidence surrounding cisplatin versus cetuximab, helping you navigate these complex, high-stakes treatment decisions.
We'll use a challenging clinical case as our anchor, which will guide us through essential concepts. From critical anatomy and modern staging nuances, to the landmark trials, agent selection exploring why cisplatin holds its place dosing principles, and critically, the long-term management of treatment toxicity.
Okay, let's dive right in and unpack this using our anchor case. So we've got a 62-year-old former smoker, and he really lands right in that challenging gray zone of modern staging.
Right.
He presents with a 3-month history of progressive pain when swallowing odynophagia, and he's also noticed a mass that's been developing on the right side of his neck.
And it's really important to flag his history here. 25 pack years of smoking. Now, he did quit 5 years ago, which is great, but that history is always a major flag.
For a couple of reasons, right?
Yeah, for prognosis, especially if this turns out to be HPV negative, but also for his general health. You're thinking about his cardiovascular and renal health, which we know will absolutely factor into our systemic therapy decisions a little later on.
Absolutely. So on physical exam, it reveals a primary tumor on the right tonsil. It's described as an exophytic mass, and it actually extends a little bit onto the soft palate.
Right.
And when you palpate the neck, he's got a pretty noticeable, firm, and actually fixed right level 2 node. It's measuring about 4 centimeters.
So it's a bulky node,
Yeah.
and it's fixed, which is concerning. The biopsy then comes back, confirms moderately differentiated squamous cell carcinoma, and here's the critical piece of information. It's P16 positive.
Right. And that P16 status, indicating it's HPV associated, that immediately just shifts the entire prognostic paradigm in his favor.
It does. But, and this is a big but, as we'll see, it doesn't completely eliminate the risk that's posed by the sheer bulk of the tumor.
Good point. So let's move on to imaging. His PET-CT really gives us the full picture. The primary tonsillar mass is very metabolically active, an SUV max of 14.
And for anyone who doesn't look at PET scans every single day, an SUV of 14 is quite hot. It tells you this is aggressive, metabolically active disease, no question about it.
And that dominant right level 2 node is also hypometabolic, SUV max of 12.
But here's the wrinkle. This is the part that really defines the complexity of this case. He also has a second involved lymph node. It's a smaller right level 3 node, measures about 1.5 centimeters, but it's still quite hot with an SUV max of 8.
So we have 2 distinct areas of nodal disease.
Exactly. 2 separate nodal levels involved.
Yeah.
The MRI confirms the primary is 3.2 centimeters. It shows that soft palate extension, but thankfully no invasion into critical structures like the pterygoid muscles or, the mandibular bone.
Okay, let's try to put this all together. We have to use the AJCC 8th edition staging system, specifically for HPV positive oropharyngeal cancer.
Right. So we have a 3.2 centimeter primary, that's a T2 lesion.
T2.
And he has 2 involved ipsilateral lymph nodes, and one of them is 4 centimeters. Now, this multinodal involvement, when you look at the HPV system, is still classified as N1.
Wait, even with 2 nodes, one of them being 4 centimeters.
Yes, provided no single node is over 6 centimeters, and there's no clear extranodal extension on imaging. So based on those rules, the patient is staged as T2N1M0.
T2N1M0. So what does that translate to in terms of the overall stage group?
Stage 1.
Right.
And this is the exact moment where, residents or really anyone reviewing the case, you kind of get this cognitive dissonance.
Right, because stage 1 just sounds so low risk. It sounds like an early stage tumor.
It does. The rules in the HPV positive system dictate that T1 or T2 primaries with either N0 or N1 disease, they group into stage 1. And that is a dramatic de-escalation compared to how we used to stage these.
Okay, so let's really unpack this central contradiction because this is a huge teaching point. Stage 1 usually suggests de-escalation. You might even think about radiation alone if the patient is ultra-low risk. So why, in this specific case, a stage 1 patient, does the standard of care remain concurrent chemoradiation?
Because you have to look past the stage number. You have to recognize the actual tumor burden. The HACC 8th edition staging system is, at its heart, prognostic. It's excellent at predicting outcomes because it recognizes that HPV-positive disease just behaves better. But the patients still have all the biological features of a locally advanced disease based on the clinical risk factors.
And what are the specific risk features in this case?
It's the multinodal disease and the size of that dominant node. I mean, if we had staged him using the older AJCC 7th edition, the presence of two distinct involved nodes, multinodal involvement, would have immediately upstaged him. He'd likely be stage 3, maybe even stage 4.
Right.
And the fact that that 4-centimeter node is described as firm and fixed, that also gives you pause. You start worrying about subclinical extranodal extension, even if you can't see it overtly on the scan.
So the teaching point for you is this. The stage 1 designation, it gives us a prognostic cushion, which is great for the patient, but the treatment intent has to address the underlying aggressive burden of the disease.
That's it, exactly. It's the multinodal involvement and the bulky nature of that dominant level 2 node. The clinical reality here completely overrides the favorable stage 1 number.
So if we were to just give this patient radiation alone, what would we expect to happen?
The locoregional failure rates would likely be unacceptably high. They would probably mirror the outcomes we used to see in historical locally advanced stage 3 or 4 disease, regardless of his HPV status. You have to treat the disease you see, not the stage number on the paper.
Okay, that makes perfect sense. Let's use this case to just quickly solidify some of the relevant anatomy and context before we move to the evidence. The primary is in the tonsil, and it's extending onto the soft palate. So what are the high-risk nodal groups we absolutely have to cover meticulously?
Well, the tonsil is a well-known site for early lymphatic spread. So the routine elective coverage targets for any tonsil primary are going to be the ipsilateral levels 2, 3, and 4.
Okay, 2, 3, and 4.
Right. And we typically would exclude level 1B unless that primary extends significantly into the oral cavity, which, it doesn't in this case.
What about the deeper chains, the retropharyngeal nodes?
Given the soft palate extension, and you have to assume there's potentially a posterior extension near the pharyngeal wall, we absolutely must include the retropharyngeal nodes in the high-dose volume.
Why is that so critical?
Because those structures drain directly from the oropharynx. And if you miss them, it's just a recipe for a central failure. It's a classic miss you can't afford to make.
And what about the other side, the contralateral side? Our patient's primary is lateralized, but that soft palate involvement it's a bit of a concern.
It is. This is a classic borderline scenario. For a truly, truly well-lateralized T1 or maybe a small T2 tonsil primary, a lot of institutions are comfortable treating just the ipsilateral neck.
But that's not our patient.
No. Since the soft palate is a central structure, the risk of lymphatic crossover, it approaches something like 15%. So for safety, especially given the stakes here, most clinicians would include at least the contralateral high level 2.
The jugulo-digastric region.
Exactly. You'd include that in the elective dose to mitigate that crossover risk, even if you're not treating the full contralateral neck levels 3 and 4.
That attention to detail covering level 2 for that midline risk is just crucial. Okay, so we've established his risk factors. 25 pack-year history, but he's PLUP16 positive, making the prognosis relatively excellent. Now, why does this patient, with his advanced burden, need the addition of systemic therapy? Why does radiation alone fail here?
The rationale is, it's really fundamental. It boils down to cell kinetics and geography. Radiation alone works by creating double-strand DNA breaks in cells.
Right.
But in locally advanced disease, and by that I mean bulky primary tumors or large complex lymph nodes, you have a very high burden of hypoxic cells. And those cells are naturally more resistant to radiation.
Right. And tumors are also a geography problem, aren't they? You're trying to clear disease over a large volume.
Exactly. When the T and the N stage advance, the probability of locoregional failure, that's the tumor coming back, either at the primary site or in the neck, it climbs to just unacceptable levels, sometimes over 40% with RT alone.
So what does the systemic therapy, specifically the chemotherapy, what does it do when you give it concurrently?
It's a radiosensitizer. Cisplatin has these properties that just increase the efficacy of radiation. It probably works by interfering with DNA repair mechanisms and maybe targeting some of those hypoxic cells.
And the key is the timing.
The key is the timing. When you deliver the radiation and the systemic agent at the exact same time concurrently, you maximize this synergy. This isn't just adding two treatments together. It's a synergistic reaction. 1 + 1 = 3 here.
And this synergistic boost, this improved locoregional control, it translates directly into the hard endpoint we all care about.
It translates directly into an overall survival benefit, and that is the entire justification for putting patients through the, frankly, increased toxicity of chemoradiation.
Okay, let's review the foundational evidence that supports this practice. We have to start with the definitive synthesis, the MACHNC meta-analysis.
The meta-analysis of chemotherapy in head and neck cancer, or MACHNC, it is just this massive data set that proves this concept across all comers. The 2021 update, led by Lakas and colleagues, it synthesized results from over 107 trials.
Wow.
Yeah, including more than 19,000 patients. It is the highest level of evidence that we have.
So what were the headline findings from that, the ones that every resident just has to know cold?
Okay, key finding number 1. Concurrent chemoradiation improves overall survival by 6.5% at 5 years.
6.5%.
And that benefit persists. It's still 3.6% at 10 years when you compare it to radiation alone. That 6.5% gain is what you are buying with 7 weeks of pretty brutal high-dose toxicity. It's the ultimate risk-reward calculation in our field.
And that answers the why. So did they find that this benefit applied to every single patient across the board?
No, and this is finding number 2, which really reinforces the need for risk stratification. The overall survival benefit was statistically significant only for stage 3 and stage 4 disease.
Okay.
There was no demonstrable overall survival benefit for patients who presented with stage 1 or stage 2 disease, when those stages are truly low risk.
And this goes right back to our anchor patient. He's stage 1 by AJCC 8th edition, but he's clinically high risk because of that multinodal disease.
Exactly. The meta-analysis suggests if he were a truly low-risk T1 and 0, the chemo benefit might not be there. But since he behaves like a historical stage 3, he needs it.
And what did it say about the type of chemo?
That was finding number 3. It cemented the agent choice. Platinum-based regimens showed the greatest overall survival benefit, and it also confirmed that induction chemotherapy giving chemo before radiation, it does not substitute for the critical effect of concurrent therapy. Concurrency is king.
Okay, so let's move now to the trial that really established the high-dose cisplatin paradigm. That's the H&N intergroup trial, published by Adelstein back in 2003.
Yes. This trial is the definitive justification for using high-dose cisplatin in the unresectable setting. It looked at 295 patients, all with stage 3 to 4B unresectable disease across various subsites, oral cavity, oropharynx, hypopharynx, larynx.
And they randomized patients into 3 arms. Arm 1 was the control, just radiation therapy RT alone, 270 gray.
Correct. Arm 2 was the one that became the standard setter. Concurrent chemoradiation. 70 gray with high-dose cisplatin, 100 milligrams per meter squared, given every 3 weeks on days 1, 22, and 43.
That's the classic schedule.
It is. It's the gold standard for maximal radiosensitization.
And then the third arm was really a cautionary tale. It was split-course chemoradiation. So they added chemotherapy, but they interrupted the radiation delivery. What did we learn from the comparison between RT alone and that concurrent chemo-RT arm?
The difference was dramatic. The 3-year overall survival was 37% for the concurrent chemo-RT arm.
37%.
Versus only 23% for the RT alone arm. That is a 14% absolute difference in survival, which is just enormous in oncology. And it was the improved locoregional control that drove that difference.
That striking survival benefit really solidified cisplatin as the standard of care. But the critical biological takeaway came from that third arm, the split-course group. Why did they do so poorly?
It all comes down to the principle of tumor cell repopulation. When you interrupt the radiation delivery, even if you add chemo, the surviving tumor cells, they start dividing and proliferating rapidly.
So you're giving them a break to recover.
You are. And this accelerated repopulation just outpaces any radiosensitizing benefit you might get, and it negates the therapeutic effect. The results were terrible, and it proves that uninterrupted delivery, that the concurrency, is absolutely non-negotiable for success.
So we accept the cost. We accept the 89% grade 3 to 5 toxicity in the concurrent arm compared to 52% in the RT alone arm.
We do. But the improved cure rate justifies the pain. The risk is accepted because the gain is a chance at a cure for what was otherwise a pretty dismal prognosis.
So now we can transition from those foundational trials to the clinical decision-making that you face every single day in the clinic. who actually needs concurrent systemic therapy?
Well, we use the risk stratification principles that are derived from those trials. RT alone, or de-intensified radiation, that's really only acceptable for patients with truly low-risk features.
Which are typically found in.
Typically in the HPV-positive OPC subset. So you're thinking T1 to T2 and 0, or maybe a T1 with a single small node, say less than 3 centimeters, and no smoking history. The best of the best.
And conversely, who are the patients that we need to push toward concurrent systemic therapy?
Anyone who presents with those historical high-risk features, regardless of their favorable stage 1 AJCC 8th staging, so that includes advanced T-stage, T3 or T4,
Right.
multiple involved nodes like our anchor patient or bulky adenopathy, so nodes that are bigger than 3 or 4 centimeters, we have to intensify the therapy to cover those areas of high tumor burden.
Okay, let's apply that algorithm directly back to our 62-year-old patient. He's got a T2 primary, but 2 involved nodes, and one of them is 4 centimeters.
That multinodal and bulky nature is the absolute red flag. Even though he's stage 1, the underlying risk profile is high. The clinical consensus is that this patient requires concurrent systemic therapy to maximize his chance of locoregional control and, subsequent cure.
So we're treating the pathology, not just the stage number.
Exactly.
So now we have to decide which systemic agent. And this is where that board-style decision algorithm really comes into play.
Right. The very first question you have to ask is the patient cisplatin eligible? If they have good renal function, good performance status, no concerning pre-existing neuropathy or hearing loss, then the answer is yes.
And the agent is cisplatin?
The agent is cisplatin.
Okay, so if they are cisplatin eligible, we have 2 classic dosing options, tri-weekly or weekly.
And this is a point of frequent discussion. What we know is that outcomes seem to correlate with cumulative cisplatin exposure. The pragmatic target, what the successful historical trials were aiming for, is approximately 200 milligrams per meter squared cumulative dose.
And how do we hit that target dose?
Well, you can achieve it with 2 to 3 cycles of that high-dose tri-weekly schedule, the 100 milligrams per meter squared per dose, or you can achieve it with 5 to 6 doses of the weekly schedule at 40 milligrams per meter squared per dose.
And the RTOG-01 Tumor 9 trial, which compared different schedules, it provides a really crucial insight here, doesn't it?
It does. That trial showed that the outcomes were pretty comparable between the different schedules if, and this is a big if the patient actually achieved the adequate cumulative cisplatin dose.
But what if they couldn't?
Then the outcomes were significantly inferior. If the planned regimen had to be stopped early, the patients did worse. And this gives us a key clinical pearl. When toxicity hits, your number 1 priority is to maintain the systemic effect.
Okay, so if our patient develops, say, grade 2 kidney issues after the first tri-weekly cycle, we don't just stop everything. What do? You
need to pivot, and you need to pivot quickly. The goal is to get to that 200 milligram per meter squared total. So you would typically switch from the tri-weekly high-dose schedule to the weekly 40 milligram per meter squared schedule.
And that allows you to.
It allows for lower peak toxicity per dose, but you're still delivering systemic sensitization over the course of the 6 or 7 weeks of radiation. Stopping entirely is considered a major clinical error.
Okay, let's drill down on this weekly versus tri-weekly debate, because while you're saying either is board safe, the difference between 40 and 30 milligrams per meter squared weekly is a really critical distinction.
Right. So board safe statement number 1. Both 100 milligrams per meter squared every 3 weeks and 40 milligrams per meter squared weekly are acceptable, provided you reach that cumulative dose. We don't have randomized data proving one is superior to the other, especially not in the modern HPV era.
But that 40 milligrams number is sacrosanct for the weekly option. Why can't we just use 30 milligrams per meter squared weekly? I mean, sometimes it's easier for patients to tolerate.
Because of data that emerged before the HPV era, it suggested that weekly 30 milligrams per meter squared was actually inferior to the tri-weekly high-dose schedule for locoregional control. So while 30 milligrams is sometimes used in post-operative settings for definitive curative intent therapy, the consensus is you have to stick with 40 milligrams per meter squared weekly to ensure adequate dose intensity and radiosensitization. If you choose weekly, you have to defend 40.
Okay, that makes sense. So this brings us to the agent that promised a softer path, cetuximab. For years, there was just this widespread hope that this EGFR monoclonal antibody could be a replacement for high-dose platinum. Where did that hope come from?
It really originated with the Bonner trial, which was published back in 2006. And this was a critical moment. It looked at 424 patients with stage 3 to 4 cancers of the oropharynx, hypopharynx or larynx, and they compared RT alone to RT plus concurrent cetuximab.
And the results were, I mean, they were revolutionary at the time.
They were. They showed a significant benefit for cetuximab. The median overall survival improved from 29 months all the way up to 49 months. 5-year overall survival went from 36% to 45%. This trial definitively established that cetuximab plus radiation is superior to radiation alone. It was an effective radiosensitizer.
But that's the crucial caveat, isn't it? It proved it was better than nothing, but it didn't prove it was as good as cisplatin, which was the existing standard of care.
Exactly. That is the critical point. The Bonner trial gave us a viable alternative. It gave us a plan B, but it left the central question completely unanswered. Can we use this less nephrotoxic, less ototoxic drug to completely replace the established standard, especially in this highly curable but still aggressive HPV-positive population?
And that brings us to the pivotal trial that delivered the sobering news. The RTOG 1016 trial, published in 2019. This one was specifically designed to answer that replacement question in the HPV-positive OPC population.
That's right. They enrolled 849 patients, all P16 positive, locally advanced OPC. Arm 1 was the gold standard, 70 gray IMRT, with triweekly cisplatin.
Okay.
Arm 2 was the exact same radiation, but with concurrent cetuximab instead of cisplatin.
And the outcome was decisive.
Yeah.
Cetuximab failed the non-inferiority margin.
Unequivocally, it failed. Overall survival and tumor control were worse with the cetuximab arm. They saw significantly higher rates of locoregional failure, meaning the cancer came back at the primary site or in the neck compared to the cisplatin arm. The idea that cetuximab was a viable substitute was just proven wrong.
And that's a massive clinical insight. If you have a curable disease, you absolutely must use the most effective treatment.
And crucially, the initial justification for cetuximab, the idea that it was less toxic, that didn't really pan out either. When RTOG 1016 analyzed the toxicity data, they found no difference in the rates of at least 1 grade 3 or 4 toxicity between the two arms.
Wait, so the overall severe toxicity rate was the same? Then what was the difference?
It was a trade-off, not an advantage. Cisplatin caused the classic toxicities we all know: nausea, renal issues, and that irreversible hearing loss.
And cetuximab.
Cetuximab caused more severe skin reactions like the acneiform rash and dermatitis, and it had worse infusion reactions. So basically you're trading kidney and ear toxicity for skin toxicity, and you're getting no gain in tumor control. In fact, you're getting a worse outcome.
The conclusion is just devastatingly clear. Cetuximab is significantly inferior to cisplatin for HPV-positive OPC. It cannot be used as a de-escalation strategy. It is strictly a backup agent.
And this wasn't just a one-off finding. We had parallel trials confirming it. The De-Escalate trial, a UK study published in 2019, randomized 334 HPV-positive OPC patients, and they also compared triweekly cisplatin to cetuximab.
And the UK team reached the same conclusion.
Absolutely. Overall survival and recurrence outcomes clearly favored cisplatin. They, too, found cetuximab led to more locoregional and distant failures, and they also confirmed that cetuximab was not meaningfully less toxic overall.
And even when the ARTScan-3 trial from Sweden used the weekly cisplatin dose, 40 milligrams per meter squared, the message was reinforced again.
Correct. ARTScan-3, published in 2021, it reinforced the message across different dosing schedules. The locoregional recurrence was significantly higher with cetuximab compared to weekly cisplatin. Cisplatin is the gold standard, period, whether you choose weekly or triweekly administration.
And just to close the chapter on cetuximab, we can't forget the RTOG 0522 trial, which explored combining the two agents. The thinking was, if both are radiosensitizers, maybe putting them together would achieve an even higher cure rate.
A reasonable hypothesis, but sadly no. That trial randomized almost 900 patients to accelerated RT with cisplatin versus accelerated RT with cisplatin plus cetuximab.
And the result was no therapeutic benefit to adding cetuximab, only increased toxicity.
Right. Specifically, worse mucositis and worse skin reactions. So the lesson here is simple. If you are cisplatin eligible, you use cisplatin alone. Cetuximab is reserved only for the cohort of patients who absolutely cannot tolerate platinum.
This brings us to a really critical step in the resident decision-making process, the cisplatin-ineligible patient. And you have to be able to define the contraindications very clearly.
Absolutely. The common contraindications are anchored in cisplatin's key toxicities. So number 1 is renal impairment. We typically define this as a creatinine clearance less than 50 to 60 milliliters per minute. If you can't clear the drug, the toxicity risk just skyrockets.
Okay, what are some of the other non-renal factors?
Ototoxicity is a major concern. If a patient has pre-existing significant hearing loss, usually grade 2 or higher, cisplatin can make it irreversible and just debilitating.
And neuropathy.
Similarly, pre-existing peripheral neuropathy, again, grade 2 or higher, is a contraindication, as cisplatin is neurotoxic and will just exacerbate it.
And then there's the catch-all, which is just the overall patient health.
Yes, poor performance status. This is often defined as an ECOG of 2 or higher, or a Karnofsky performance score below 70. These patients simply cannot withstand the acute toxicity demands of high-dose platinum.
Okay, let's walk through the decision framework for the patient who is definitively cisplatin ineligible.
Right. Step 1, confirm and document the reason for ineligibility. This is key for board defensibility and, more importantly, for patient safety.
Okay. Step 2, if the patient is cisplatin ineligible but can tolerate some systemic therapy, so they have acceptable performance status, just bad kidneys or bad ears, what are your 2 primary backup options?
Option A is cetuximab. We know it's inferior to cisplatin, but the Bonner trial showed it is superior to radiation alone, so it remains a defensible systemic option when platinum is contraindicated.
And option B?
Option B is a carboplatin-based regimen, for example, carboplatin with 5-FU. The evidence is less definitive than for cisplatin, but carboplatin is less nephrotoxic, and it's an acceptable alternative. This is often guided by institutional preference.
Okay, and step 3. This is the most frail patient. The one who cannot tolerate any systemic therapy, maybe due to profound comorbidity or just extremely poor performance status.
For that patient, you default to radiation alone, but you must intensify the radiation technique itself to compensate for the lost radiosensitization. And this means using altered fractionation RT alone.
I want to briefly just mention the newer agents here. There was some hope in the NRG HDEN-004 trial that maybe we could substitute a checkpoint inhibitor like durvalumab for cetuximab in this ineligible population.
Right, that trial was comparing durvalumab to cetuximab in the definitive cisplatin-ineligible setting. It actually stopped early for futility.
Ah.
Yeah, durvalumab did not improve outcomes, and the local regional control was not any better. So this confirms that substituting a checkpoint inhibitor for cetuximab in definitive therapy is not supported outside of a clinical trial. The board-safe answer remains cetuximab or carboplatin as your backups.
So the board-safe ladder is firm, cisplatin if eligible, cetuximab or carboplatin if cisplatin ineligible, but they can tolerate some systemic therapy, and altered fractionation RT alone if they can't tolerate anything systemic.
Exactly. The Bonner trial gives us the foundation for justifying cetuximab over RT alone when cisplatin is truly off the table.
Okay, let's transition to the technical aspects. Dose and fractionation for definitive chemoradiation. We often see subtle variations here.
The global standard dose is 70 gray, and it's delivered in 33 to 35 fractions, which is approximately 2 grays per fraction. The difference between 33 and 35 usually just comes down to whether a simultaneous integrated boost or SIB technique is being used.
And the delivery schedule, what's most common?
The most common schedule remains the standard, 70 gray and 35 fractions, delivered 5 days per week over 7 weeks. However, some protocols, most notably RTOG 1016, used a 6 fraction per week schedule to shorten the overall treatment time down to 6 weeks.
And it's important for residents to remember that critical lesson from the Adelstein trial. Maintaining continuous, uninterrupted delivery is key. But why hasn't acceleration with concurrent chemotherapy become the standard?
Because accelerated RT with concurrent chemo just has not consistently shown improved outcomes compared to standard fractionation. And it significantly increases the acute toxicity burden, especially mucositis and skin reactions.
So we save acceleration for?
We generally reserve acceleration, that's shorter overall time. For the scenarios where we are not using concurrent chemotherapy, we're using it to try and overcome tumor proliferation kinetics in that setting.
Okay, let's circle back to our case patient to review the nodal coverage in detail, because this is really where a resident demonstrates mastery of anatomy and risk. So retonsil primary, soft palate extension, right level 2, 4-centimeter node, and our right level 3, 1.5-centimeter node.
Right. The goal is to cover all potential microscopic disease. So for tonsil primary, our ipsilateral coverage needs to include levels 2, 3, and 4, as level 4 is the next drainage level down the jugular chain.
Okay.
And we're also covering the retropharyngeal nodes, as we discussed, because of that soft palate extension approaching the midline.
And what dose are we giving those elective nodes? We're not treating all of that to 70 gray.
No, absolutely not. We use an intermediate dose, typically an equivalent dose in 2 grays, or EQD2, of at least 46 gray. Sometimes you go up to 54 to 56 gray SIB for intermediate risk elective areas, especially level 2, which is right next to that bulky disease.
Now, let's just revisit that contentious issue of the contralateral neck coverage for this specific case. Soft palate extension suggests midline risk.
It's a classic dilemma. While there's retrospective data that supports ipsilateral-only RT for truly lateralized T1 or T2 tonsil primaries, our patient has that soft palate extension.
Which changes everything.
It significantly increases the risk of contralateral subclinical disease. So to ensure regional control, most experts would include at least the contralateral high level 2, so level high A, and treat it to an elective dose, maybe 50 to 54 gray SIB. This provides safety against crossover.
We mentioned earlier that for the patient who can't tolerate any systemic therapy, we default to altered fractionation RT alone. We need to know exactly how much benefit that provides and why it's necessary.
Right. Altered fractionation is our last line of defense when we can't use platinum or cetuximab. The March meta-analysis, published in 2017, actually quantified this benefit for us.
And what was the absolute gain?
Overall, altered fractionation RT alone provided a 3.1% absolute overall survival benefit at 5 years over standard RT alone. But the most effective approach was hyperfractionation.
Hyperfractionation.
That provided a much more robust 8.1% survival benefit.
So hyperfractionation is the best non-chemotherapy option. Why does it work biologically?
Well, it comes down to the 4 R's of radiobiology, especially repopulation. By giving 2 smaller doses per day, usually separated by 6 hours, we can kill tumor cells but allow healthy normal tissues to repair in between. More importantly, we accelerate the total dose delivery, which minimizes the time available for those tumor cells to repopulate.
Can you remind us of the logistical demands of hyperfractionation? Let's use the classic RTOG 9003 schedule.
It is challenging, both for the patient and the department. It delivers 81.6 gray in 68 fractions, using 1.2 gray twice daily. The crucial constraint is you must have a 6-hour separation between the 2 daily fractions.
And that's to allow for?
That's to allow for sublethal damage repair in the normal tissues, which minimizes late toxicity while still maximizing tumor cell kill.
Okay, so we've established the treatment plan for our anchor patient. Concurrent cisplatin, standard fractionation, 70 gray with meticulous level 2, 3, 4, and retropharyngeal nodal coverage, and likely contralateral level 2 coverage. Now we have to face the reality of toxicity management. Let's start with acute toxicity.
Acute toxicity it's brutal. It's the defining experience for these patients. Mucositis is the most common and the most limiting acute effect. It typically peaks around weeks 5 to 6 of treatment.
And we're talking severe mucositis.
We are. It affects 60 to 80% of chemoradiation patients at a grade 3 or higher severity, which means they're on narcotics and are unable to swallow solids.
And management is just intensely supportive.
Absolutely. Frequent rinse of salt and soda topical agents like lidocaine or magic mouthwash, aggressive systemic analgesia, and, most critically, nutritional support.
And that leads to the perennial debate. Prophylactic versus reactive PEG placement, the feeding tubes.
It's highly institution dependent. There's no single right answer, but the trend has been toward fewer prophylactic PEGs for low-risk HPVV patients. But regardless of the approach, early involvement of the nutritionist and the speech-language pathology team is mandatory.
What's the one thing you can't skip?
The crucial, non-negotiable monitoring tool is weekly weight checks. If a patient loses more than 10% of their body weight, intervention is absolutely mandatory.
Now, when we talk about cisplatin-specific acute toxicities, what are the 3 major issues that you are monitoring for every single week?
Okay, number 1 is nephrotoxicity. We aggressively hydrate pre- and post-infusion to try and flush the kidneys, and we are monitoring creatinine closely before every single cycle.
Hi, number 2.
Number 2 is ototoxicity. This is often an irreversible high-frequency hearing loss. We must establish a baseline audiogram before treatment and counsel patients very heavily on this risk.
And the 3rd major challenge?
Nausea and vomiting. Cisplatin is highly emetogenic, so we use aggressive, multi-agent antiemetic prophylaxis, often including NK1 inhibitors like aprepitant, to maximize compliance and minimize suffering.
Okay, now let's shift to late toxicities.
Mhm.
These are the quality of life defining effects that the patient lives with long after the tumor is cured. What's the most common long-term complaint you hear?
Xerostomia, chronic dry mouth. It impacts eating, speaking, dental health. It's significant. The critical goal for radiation planning is to limit the parotid mean dose to less than 26 gray. And even with IMRT, recovery can take up to 2 years, and for many, it's never complete.
And what about late dysphagia? That can be progressive and debilitating years after treatment.
Dysphagia is driven primarily by the dose that's delivered to the pharyngeal constrictor muscles, especially the superior and middle constrictors, and structures like the cricopharyngeus and the larynx. The key intervention here is proactive, long-term swallowing rehabilitation.
So they have to keep doing exercises.
Patients must continue swallowing exercises indefinitely to maintain muscle flexibility and reduce the risk of stricture or aspiration.
And we also have the endocrinopathy risk because of the neck field.
Yes, hypothyroidism is incredibly common. It occurs in 30 to 50% of patients who receive radiation to the thyroid gland. So we mandate monitoring of TSH every 6 to 12 months indefinitely because it can develop years later.
What else?
We also need to be mindful of accelerated carotid stenosis, which can happen due to the high dose delivered to the carotid arteries, particularly in patients who, like our anchor patient, have a history of smoking and other cardiovascular risk factors.
And finally, the big one, the late complication that can lead to surgical intervention. Osteoradionecrosis, usually of the mandible.
The risk of ORN increases significantly with the dose delivered to the mandible. The mandatory pre-treatment step is rigorous dental clearance. Any teeth that are non-restorable or questionable must be extracted before radiation starts. The risk is dramatically higher if teeth are extracted after the radiation dose has been delivered.
Let's consolidate this knowledge by discussing 3 critical clinical decision errors that often come up when managing these patients. These are the pitfalls you need to anticipate and avoid.
Okay, the first major clinical error: recommending cetuximab as a primary de-escalation strategy for a cisplatin-eligible HPV-positive patient.
And why is this so wrong, given all the hope that surrounded it?
Because the evidence is just overwhelming. RTOG 1016 proved it was inferior for survival and for local regional control, and the de-escalate trial showed it had no overall toxicity advantage. So you are risking a worse outcome without improving quality of life. You only recommend it as a backup for truly cisplatin-ineligible patients.
Okay, what's the second major error?
Stopping systemic therapy entirely after the first cycle due to manageable toxicity, like grade 2 nephrotoxicity or severe nausea.
And this error stems from forgetting what principle?
It stems from forgetting the principle of cumulative dose. Outcomes correlate with that cumulative 200 milligrams per meter squared target. If toxicity emerges, the correct clinical move is to adjust the schedule switch to weekly 40 or switch to carboplatin, but you cannot stop systemic therapy entirely after just one cycle unless there's a life-threatening complication. Suboptimal cumulative dose leads to suboptimal outcomes.
And the third critical error?
Using altered fractionation to completely replace chemotherapy and stating that the benefit of hyperfractionation is equivalent to concurrent chemoradiation.
And that's wrong, because...
That is just factually incorrect.
Yeah.
Concurrent chemo-RT beats altered fractionation alone. While hyperfractionation is the superior form of radiation alone, it remains a second-best option. It's used only when absolutely no systemic agent, not cisplatin, not carboplatin, not cetuximab, can be tolerated.
Okay, let's run through a quick review of these concepts using some practical decision scenarios.
Okay, scenario 1. A 55-year-old woman with P16 positive OPC T2 presents with a single 4.5 centimeter ipsilateral node. She is cisplatin eligible. What is the most appropriate concurrent systemic therapy? Is it A, cetuximab weekly, B, cisplatin 100 milligrams per meter squared every 3 weeks, C, carboplatin AUC 5 with 5FU, or D, radiation alone is sufficient?
The correct answer there is B. Cisplatin 100 milligrams per meter squared every 3 weeks, or weekly 40 is the standard.
And the rationale is clear. She is cisplatin eligible, and that 4.5 centimeter node is bulky nodal disease, so it justifies intensification. Cisplatin is the gold standard. Cetuximab is inferior, and RT alone is insufficient for this tumor burden.
Okay, scenario 2, addressing that toxicity challenge. A 68-year-old man with locally advanced OPC developed grade 2 nephrotoxicity after cycle 1 of cisplatin. His creatinine went from 1.0 to 1.8. His team is considering stopping all systemic therapy. What is the best recommendation?
A, stop systemic therapy. 1 cycle of cisplatin is sufficient. B, switch to cetuximab for the remaining treatment. C. Continue with weekly cisplatin 40 milligrams per meter squared with close monitoring. Or D. Proceed with radiation alone for the remainder of treatment.
The best answer has to be C. Continue with weekly cisplatin 40 milligrams per meter squared.
Exactly. One cycle is not enough for a cure. The priority is achieving that adequate cumulative systemic dose. Switching to the weekly schedule allows for dose intensity modification. It reduces the peak renal burden, and you continue that critical radiosensitizing effect with careful monitoring.
Right. A and D are just clinically incorrect, and for B, you'd exhaust attempts to continue cisplatin first.
Correct. You try to stick with the superior agent if you can do it safely.
Okay, last one. Scenario 3, testing your understanding of the cetuximab evidence. Which of the following statements about cetuximab in HPV-positive OPC is true? A. Cetuximab is non-inferior to cisplatin when combined with radiation. B. Cetuximab has a more favorable overall toxicity profile than cisplatin. C. Cetuximab plus radiation is superior to radiation alone. Or D. Adding cetuximab to cisplatin-based chemoradiation improves overall survival.
The correct answer here is C. Cetuximab plus radiation is superior to radiation alone.
And this statement is historically correct based on the Bonner trial, which established cetuximab as a viable treatment option that was better than radiation alone, and that's what justifies its use as a backup agent.
That's right. A and B are proven false by RTOG 1016 and de-escalate, and D is proven false by RTOG 0522.
Okay, let's end this comprehensive review with some high-yield clinical pearls that tie all these concepts together, bringing it back to the clinical reality of treating patients like our 62-year-old former smoker.
Okay, Pearl 1. Cisplatin is king. Concurrent cisplatin, established by Edelstein's H&N intergroup trial, is the standard. And remember, MACH and C showed only concurrent chemo consistently improves overall survival for locally advanced disease.
Pearl 2. Aim for a cumulative dose around 200. If toxicity emerges, especially the renal or hematologic kind, you have to modify the schedule. You switch to weekly 40 milligrams per meter squared rather than stopping systemic therapy outright. It is all about cumulative exposure to maximize the probability of a cure.
Pearl 3. Weekly 40, not 30. If you are using weekly cisplatin for definitive therapy, the dose must be 40 milligrams per meter squared. The data suggests 30 milligrams per meter squared weekly is just insufficient for local regional control compared to the high-dose regimen.
And Pearl 4. Cetuximab is a backup, not de-escalation. It is an inferior systemic agent compared to cisplatin. It lacks a true overall toxicity advantage, and it is reserved only for patients who are definitively cisplatin-ineligible. Do not fall into that trap of recommending it as an easier path for a curable patient.
Pearl 5. Chemo-RT beats altered fractionation alone. Altered fractionation, even hyperfractionation, is superior to standard RT alone, but it remains the inferior, third-best option used only when no systemic agent can be tolerated.
And Pearl 6, anchored by our case. Multinodal disease equals high risk. Even with a favorable Stage 1 AJCC 8th stage grouping, the presence of multiple involved nodes or bulky adenopathy warrants the full intensity of concurrent systemic therapy. You have to treat the tumor burden, not just the stage number.
Today we covered the essential framework for definitive chemoradiation in locally advanced head and neck cancer, focusing on how evidence from landmark trials dictates the choice between cisplatin and cetuximab and how to apply those rules to challenging clinical scenarios.
So to quickly recap the essentials for you.
Sure.
First, that 6.5% overall survival benefit we gain comes from concurrent chemoradiation for locally advanced disease. Concurrency is absolutely key.
Second, cisplatin is the preferred agent. You can deliver it tri-weekly or weekly with the goal of hitting approximately 200 milligrams per meter squared cumulative dose.
Third, cetuximab is inferior. It's reserved only for cisplatin-ineligible patients, where the Bonner trial proves it is better than radiation alone.
Fourth, late toxicities, especially xerostomia and dysphagia, define quality of life. Their treatment planning must meticulously focus on minimizing dose to the parotids and pharyngeal constrictors and ensuring strict pre-treatment dental clearance.
And finally, always use the underlying risk features, bulky nodes, multinodal involvement, to determine your treatment intensity, ensuring your therapeutic choices align with the strongest evidence of cure.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.